Welcome to our video on ectopic pregnancy. Let's get started. Here's our overview slide. Let's begin with an introduction. Ectopic pregnancy happens when a fertilized egg implants outside the uterine cavity. Normally, the fertilization process takes place in the ampulla. After fertilization, the egg travels to implant in the endometrial cavity as part of normal pregnancy. So, when the fertilized egg implants in areas other than the endometrial cavity, it leads to ectopic pregnancy. The ampulla is the most common site of implantation in ectopic pregnancy. The isthmus and the fimbrial parts of the fallopian tubes can also be involved. Other sites include the ovary, cervix, and previous cesarean scars. Here is an image showing various sites of implantation in ectopic pregnancy. In a normal pregnancy, the implantation occurs in the uterine cavity. Whereas in ectopic pregnancy, the implantation can occur in the tubes, the ovary, the interstitium, or the cervix. Here are some of the risk factors associated with ectopic pregnancy. A history of previous ectopic pregnancy increases the risk in subsequent pregnancies. Some other notable risk factors are prior tubal surgery and pelvic inflammatory disease, as these can disrupt the normal tubal anatomy and alter the function of the tubes. Women with endometriosis are also at risk, as this can damage the tubes and ovaries by scarring the tissues. Contraceptives such as intrauterine devices and oral contraceptive pills and smoking can alter the motility of the fallopian tubes and increase the risk of ectopic pregnancy as well. Symptoms usually occur after 6 to 8 weeks from the last menstrual period. Patients often present with lower abdominal pain, tenderness, and vaginal bleeding. A pelvic exam may reveal cervical motion tenderness and a closed cervical ostium. When tubal ectopic pregnancy progresses, the fallopian tubes begin to expand and eventually rupture. In such cases, patients present with features of hemorrhagic shock, such as hypotension, tachycardia, and unresponsiveness. Signs of peritonitis, such as rebound tenderness and guarding, may also be seen. The diagnosis can be made by a history and clinical examination. A female with a history of amenorrhea, abdominal pain, and vaginal bleeding is a classic scenario. A complete blood count may show decreased hemoglobin levels due to blood loss. And transvaginal ultrasound is the standard imaging test performed. It may show the gestational sac located outside the uterine cavity and a blob sign in tubal pregnancy. Blob sign is also called the tubal ring sign and is described as an echogenic ring surrounding the unruptured tubal pregnancy. Exploratory laparoscopy can be performed to confirm the diagnosis. Here's an image of a transvaginal ultrasound that shows tubal ectopic pregnancy. It appears as a spherical mass or a blob, known as the blob sign. Also notice that this patient has an intrauterine device in the uterus, which is a risk factor for ectopic pregnancy. Now let's move on to management. Unruptured ectopic pregnancy can be managed medically or surgically. Methotrexate is the drug of choice for medical management only in unruptured cases. Surgical management includes laparoscopic salpingostomy or salpingectomy. A rupture is suspected if the patient has sudden onset severe abdominal pain and hemodynamic instability, such as a drop in blood pressure, tachycardia, or unresponsiveness. A ruptured ectopic pregnancy requires resuscitation with IV fluids and blood transfusion in cases of excessive blood loss. Emergency exploratory laparotomy is performed to remove the ectopic pregnancy. In Rh-negative women, anti-D immune globulin is administered to prevent alloimmunization. Here's a laparoscopic view showing the uterus and ectopic pregnancy on the left fallopian tube. The left fallopian tube appears enlarged and bluish due to the collection of blood, which is termed hematosalpinx. All right, let's finish up with a review question. A 28-year-old G1P0 female is brought to the physician at 5 weeks of gestation due to severe lower abdominal pain. She started feeling pain 3 hours ago, and it has worsened since then. She prefers to lie still on the stretcher because even a slight movement exacerbates her pain. She has a past medical history of pelvic inflammatory disease. She is Rh negative while her husband is Rh positive. Transabdominal ultrasound shows an enlarged right fallopian tube and blood in the pouch of Douglas. The patient undergoes exploratory laparotomy for presumed ruptured ectopic pregnancy. What additional intervention should be performed? All right, this female with a past medical history of pelvic inflammatory disease has severe lower abdominal pain with an enlarged right fallopian tube and blood in the pouch of Douglas. She is presumed to have a ruptured ectopic pregnancy, and she undergoes exploratory laparotomy. Ruptured ectopic pregnancy increases the risk of fetal-maternal blood mixing. Since she is Rh negative while her husband is Rh positive, she needs to receive anti-D immune globulin to prevent alloimmunization against fetal Rh antigen. And that concludes our section on ectopic pregnancy.